beyond the irregular pulse, atrial fibrillation for non-cardiologists. And I would like to welcome Dr. Amit Govil to introduce our speaker today, as well as the moderator, Dr. Amit Govil. Thank you.
Yeah, hi. Good evening, everyone. And I just, for some reason, my camera is giving me trouble, but I don't need to be seen anyway. So it gives a great pleasure to introduce our speaker for today, Dr. Gaurang Gandhi, who is a chair, Department of Cardiology, chaired Cardiology Quality Assurance Committee, Director Electrophysiology, Tri-Health Heart and Vascular Institute, Bethesda North Hospital in Cincinnati, Ohio. And he'll be talking about beyond the irregular pulse, atrial fibrillation for non-cardiologists. And that's something which all of us have probably come across, whether it's in day-to-day management and pre-op or post-op, and we deal with these patients where we just don't know what to do many a times and when to call cardiologist or when to intervene and all that. And to moderate the session, we have a distinct pleasure of Dr. Anjali Gulati, who is invasive cardiologist in San Jose, California, being trained at Stanford University, highly accomplished cardiologist who also is very actively involved in AAPI and is a regional director for Pacific 1 region. So I just want to welcome all of them, and we look forward to your talk, Dr. Gandhi. Please take it over. Thank you.
Thank you, everybody. So I'm Gaurang Gandhi, and I'm in Cincinnati, and just a mic check and the slide check. Everybody can see hear me well, and the slide check is good?
Dr. Gandhi, very quickly, if anybody has any questions, please either send it in the chat directly to me or in the group chat, and we'll keep the answers at the end of Dr. Gandhi's talk. Thank you.
All right, if the mic check is good and the slide check is good, then thank you very much, first of all, to Satish as well as Amit and Anjali for hosting this meeting. I've got the disclosures just for CME purposes, and one of the disclosures that I have not put here is whoever is signed in needs to show up at the end of July for the conference, which we are very excited to host. And I think it'll be a great conference. Satish and everybody else is working very hard. So please, please, please come to Cincinnati. It's a beautiful town. And I think you will not regret joining this meeting. It's going to be an awesome meeting. So please, please, please come. Okay, atrial fibrillation. I mean, this is something that I want to talk about today. I'm an electrophysiologist by profession, so I do deal with atrial fibrillation on a daily basis. But my wife is a primary care physician, and she deals with atrial fibrillation more than I deal with. And then I've got Amit and everybody else that deals with AFib every day. So I said, okay, let's talk about this topic. So I want to understand the clinical spectrum of atrial fibrillation today with you guys. And depending on who you are, how can you provide the provider's role for diagnosis as well as risk management? Every time you're going to have a standstill as soon as there is some patient in your office, whether you're doing a kidney transplant or you're doing a biopsy or delivering a baby, and there is an AFib and there is a standstill, lull, like what do we next? It all depends on the clinical needs, and hopefully I'll address that. And obviously, I'm very proud of the electrophysiology division at Tri-Health, as well as what I have achieved over 21 years after my training is advances. And one of the most exciting branch even today is current options with atrial fibrillation, where we always used to say atrial fibrillation is you can control but not cure. And I can still say that we still control, but I would use the oncology term of remission. We can create remissions of years together, and in some select few patients we can cure. And obviously we can treat patients that will lead to less consequences of atrial fibrillation that we'll discuss. So with that, and with the permission of the moderator, I will proceed with my presentation. And I'm going to ask this, and I'm sure we all have seen patients like this. Preoperative evaluation in a primary care office of an 80-year-old female with ovarian tumor, probably cancer with probable stage 2, needs surgery for diagnosis, staging, and therapy. Prior EKG 4 years ago, normal sinus rhythm, no other cardiac testing. She has been a very healthy female, no other medical issues. Only complaint you ask her for this particular visit because it's a pre-op visit, well, feels tired for the last 1 year, otherwise no other significant symptoms. Has history of a little bit of hypertension, well controlled on diabetes, on oral agent, hemoglobin around 10, all other labs normal, and you have to sign this paper says, yep, you can do this surgery, and next is this EKG, and like, okay, now what do I do? Is the treatment right now I need to worry about AFib first, or do we worry about the ovarian tumor, which could be cancer, which could be something that is a catastrophic disease, and maybe the patient needs some urgent care? So this is where the dilemma is. So I'm going to leave this dilemma in your head. Think about a patient that I'm sure we all have come across in our clinical practice or spectrum in the last 1 week, or probably in the last 24 hours. And think about, for your own practice, what would you do next? And then we'll try to answer this question after I'm going through several aspects of atrial fibrillation to achieve the aim of getting the clinical spectrum of AFib and why we are talking in 2025 AFib. So basically this patient, the questions are, cancel or proceed with the surgery? Do I start anticoagulation? Or just, hey, I'm going to find the cardiologist or electrophysiologist, and yeah, Anjali is not available because she's so busy, and I'm not available because I'm in the lab, and like this patient needs a clearance. What are you going to do next? So think about it, pause. We'll move on with the next topic, which is atrial fibrillation. We are talking today is an epidemic. If you look across from 2005 to now, or even later, it is an epidemic, I would say, much bigger in spectrum than what we think. And it's all across. If you look on the right side of the slide, it affects everybody. Doesn't matter if you are a white. It's atrial fibrillation is considered to be a European disease. Luckily, Indians don't get that much. Afro-Americans don't get that much, but it's just something that we are not diagnosing, or sometimes we don't have capacity to diagnose these things, but it's increasing all across the board. If you look at it from 4.49% to 6.82% from 2015 to 2019, this is pre-COVID pandemic. And yes, atrial fibrillation becoming a little bit less in the conventional people, but it's definitely there. So let's look at what can cause and what can contribute to atrial fibrillation. I want to go in a very scientific way. So advancing age, yep, this country as well as a lot of us are getting into the stage where there are a lot of people that are growing older, and that's one of the reasons people have atrial fibrillation. I answered this question multiple times to a 90-year-old guy. Why do I have atrial fibrillation? I did everything right. And like, sir, if you live 200 years, and I believe that every human being, if they live 200 years, they will have atrial fibrillation, because that's one of those things that happens. But there are several things we have done to ourselves: smoking, alcohol intake, obesity, pretty rampant in Midwest where I live, hypertension, coronary artery disease, valvular heart disease, something that is very close to people who got trained in India with mitral stenosis. Atrial fibrillation was hand in hand, and several other reasons like calcific aortic stenosis, congestive heart failure, thyroid disorders, COPD, pulmonary embolism, sepsis, and commonly we encounter if you work in a hospital setup is surgical as well as anesthesia stress. So these are all causative contributing factors that affect every patient that we take care of in our lifetime, whether we are a primary care physician, a cardiologist, electrophysiologist, a nephrologist, a renal transplant guy, a surgeon, OBGYN. We are going to see this all across the spectrum. So that's the spectrum of atrial fibrillation, and with almost to a point where this is going to be a problem for a long period of time. So if you see somebody who is at all these risk factors, I'll go back on the slide: age, smoking, alcohol, obesity, hypertension, CAD, valvular disease, and all, what do I do next? And there is a significant, I'm actually participant of a research trial where can I predict atrial fibrillation the next 5 years in this patient just based on EKG that is normal sinus rhythm? And the answer is going to be yes in the near future. But what can I do as a provider? And I don't have to be a cardiologist. I don't have to be an electrophysiologist. But one of the recommendations, so if you see in my slides today, which are all taken from American Heart Association and ACC guidelines, and COR is the level of recommendation. So 1 is the recommendation, and then level of the evidence we have. And so there's no randomized trial, but it's significantly higher. Instead of a C, it's a B. And patients who you feel is increased risk of atrial fibrillation should receive comprehensive guideline directed lifestyle modification. I think this is one we are forgetting all the time because it's good for business to have AFib and do ablation, but I think it's a much better way to handle patients who can we prevent atrial fibrillation. So targeting obesity, physical inactivity, unhealthy alcohol consumption, smoking, diabetes, hypertension, treating all those things are very important. This can all, we have evidence enough, not randomized trials, but enough that we can say that we can or we should be able to prevent or at least reduce the risk of atrial fibrillation for a long term, being part of population health, being part of doing the right thing for our patients that can lead to some catastrophic consequences of atrial fibrillation. We'll deal in the next few minutes. So that's primary prevention of atrial fibrillation. And I always like to bring this slide up because we are not paying attention to this thing in the initial phase, and we should be preventing this because this can lead to really a lot of improvement in our patients and less decreased incidence of atrial fibrillation, which we are seeing in the epidemic proportion at this point in time. Definition of atrial fibrillation is basically anybody who has irregular heartbeat. And if somebody converts in less than 7 days, and I'm going to bring this slide, and the only slide which is technical is because I think it's very important, is if somebody converts spontaneously in 7 days, it's paroxysmal. Anything more than 7 days, and I have to do something as a physician, cardioversion, medication or anything, and if it lasts for more than 7 days, it's persistent. And permanent is something that we have decided this patient either does not need any therapy because patient is in AFib for a while, failed cardioversion, or we decided because patient is too risky. And anything more than one episode, 2 or more episodes is recurrent atrial fibrillation. And this spectrum is so important and so to remember. 7 days, I think, are arbitrary, but basically, this is funny, and I'm going to take this since we are all friends and family here with AAPI, is paroxysmal is like a date. You can get rid of a cheap date and not worry about it. Persistent is like a girlfriend. You have to really actively work on it, getting rid of a girlfriend. Permanent is getting married, and then it's not going to work eventually to get rid of this atrial fibrillation. So that's my very crude, I'm sure I'm going to get in trouble in 1 hour from now when I get out of this meeting room. And recurrent is more than 2 episodes of atrial fibrillation. So it's important. Treating paroxysmal atrial fibrillation is much easier than persistent. Living with permanent atrial fibrillation, yes, you can live with atrial fibrillation, but on the long term, there are going to be consequences of atrial fibrillation, which are arrhythmia symptoms, dizzy, lightheaded, feeling tired. Some of them are very mixed. We could go with a lot of other things. We talked about obesity, COPD, but shortness of breath, all those things. The important functional evidence-based is reduced ejection fraction. So patients can have cardiomyopathy, decreased exercise tolerance, and definitely affecting their quality of life over a period of time is very important. One of the reasons is because your heart rate is so fast that patient develops tachycardia-induced cardiomyopathy. Now you're in a situation, now it becomes life-threatening, risk of having sudden cardiac death, heart failure, recurrent admissions, and increasing cardiac mortality twice. Somebody who has atrial fibrillation is at least higher by 2 times more than somebody who does not have atrial fibrillation after negating age, sex, hypertension, diabetes, or anything. It's twice. Worse is the risk of stroke, which we all fear and dread about atrial fibrillation, is 5 times higher risk of stroke in somebody who has everything else but no atrial fibrillation. And this is a significant burden to healthcare systems, emergency room, night calls at night, like how many calls we fill for night if you are in the as a primary care or hospitalist, and how many patients get admitted is a significant burden to healthcare that I think we all can contribute in decreasing that if we treat it at an appropriate time with adequate medications or expertise. Atrial fibrillation causes stroke. We all know that. It's a leading cause of stroke, 5 times more chance. 1 in 6 strokes is because of atrial fibrillation. The problem is patients of atrial fibrillation who had 1 stroke will have another neurological event in less than 6%, almost 50% of the time. So 1 stroke with atrial fibrillation, we have so much to do for this patient to avoid that 50% of patients not getting back into the hospital, not decreasing their quality of life or functionality is huge. And people who have atrial fibrillation-related stroke do much poorly than patients who have stroke because of not atrial fibrillation. And we are talking about doubling up the population. This was a census, 6 million in 2018. 2030, most of us are still working or will be working. We are going to see 12 million patients in this population of USA that will have atrial fibrillation. And we can do a lot of stuff for these patients with availability of modern technology, as well as using the goal-directed therapy and lifestyle modification that can prevent atrial fibrillation. Or if they have atrial fibrillation, we'll talk about what we can do, not as an electrophysiologist, not as a cardiologist, but as a doctor who's taking care of our patients over years. So number one, the stroke, we are going to talk about it, and then we'll shift gears to something else. So number one is how in your office you can determine stroke. And I think every medical physician, APP, anybody who's taking care of a patient has access to this medical record. So remember our patient, 80-year-old female. So you already got points here. So congestive heart failure, if somebody has congestive heart failure, you get 1 point. Patient has hypertension, you get 1 point. Patient's age is more than 75, 2. If age is less than 75 but more than 65 is 1. Stroke in the past is 2. Vascular disease could be coronary artery disease, myocardial infarction, peripheral artery disease, or aortic plaque is 1. Diabetes and female. And this is very important because next slide is going to be if the stroke is 0, none of this thing applies to you. You're a 44 guy, atrial fibrillation, no big deal. You're not going to have a stroke in the next near future. But if you are an 80-year-old female with hypertension and diabetes, you're already putting yourself at 6, which is 9.8% stroke per year. So every year, 10% chance of having a stroke. If somebody lives 5 more years, 50% chance, 1 in 2 chance of having a stroke. Such a high risk of stroke because it's a cumulative risk. It's not per year per person, but every year you add on. So 80-year-old female, if he is going to live 90 years and you're not going to give a blood thinner on this patient, not identify atrial fibrillation, almost 100% chance the patient will have a stroke. And that is very important for every physician to identify this because we have therapies and we have got a very good guideline-directed therapy on this particular spectrum. And I'm going to go through 3 in the next 5 minutes to 7 minutes to show what we can do for these patients in a very guideline-based way, safe way, and applying all the medical care that is available in 2025, and it's going to get better and better as we talk about this thing. The reason patients have stroke, and I hope you can see my pointer, is there is something called a left atrial appendage in the left atrium, which is a vestigial organ that has not resolved. And as we grow older and atrial fibrillation, there's a stagnation of blood leads to formation of a clot that can embolize and ultimately end up in an embolic phenomenon, most likely leading to a stroke and usually a devastating stroke. So it's an embolic stroke that can be very devastating. We prevent this by giving blood thinners, and you'll see the other spectrum. If we have any neurophysicians, neurosurgeons in the crowd, they'll say, oh, yeah, but I see you guys give Eliquis to this patient, and next thing patient came with massive bleed in the brain that I could not make this patient better, and patient ultimately ends up with hospice and ventilation and withdrawal of care. And this is our day-to-day life story that we see, giving a blood thinner or not giving a blood thinner. And so I think we always go to the guidelines because I think guidelines are very goal-directed therapy for patients who are at risk, and how do we avoid complication, but at the same time provide the state-of-the-art care. There's also something like a Hasbled score, which predicts high risk of bleeding if you are hypertensive, abnormal renal function, abnormal renal function, age more than 65, stroke in the past, bleeding in the past, INRs if you are on blood thinners like warfarin, taking other drugs that interact, or alcohol intake, those all get 1 point. And if you think the patient is a high risk of bleeding, we want to be very careful. And one of the things every physician who sees a patient with atrial fibrillation should, by recommendation as well as from level of evidence, is patients with atrial fibrillation should be evaluated for the annual risk, because as we know, age changes, people can develop diabetes, people can have hypertension, it changes. And the CHA2DS score is one of the systems. There are multiple systems. I didn't want to bring it up because this is one of the commonest used in US but it helps. If the CHA2DS increases, the recommendation changes based on the CHA2DS score. Also, on the other side, we want to be very careful who are going to bleed and making that assessment. If the patient is becoming frail, fall risk, patient has now GI bleed, patient had intracranial bleed because patient fell, or patient has subdural or subarachnoid hemorrhage because of hypertension. Those are all very important things to play, and it changes 6 months, every year, every 2 years. So having that assessment is definitely a recommendation that is of level 1 with significant evidence at non-randomized studies that it is important to look for it. And the answer is very simple. So stroke and systemic embolic event risk threshold for anticoagulation. If anybody anticoagulation risk assessment is at 2% per year, we should be using anticoagulation. And the preference is DOACs, which essentially at this point in time, to be very technical, are 2 rivaroxaban 20 milligrams or apixaban 5 milligrams twice a day. However, if patient has valvular disease like mitral stenosis or mechanical, anticoagulation with warfarin is the most recommended. If it is between 1 to 2%, it is still reasonable to use an anticoagulation. However, if there are no risk factors, it's very important. This is a very important slide, I think. Post-stroke, aspirin to prevent thromboembolic events is not recommended. It can lead to harm in some patients. And aspirin, either alone or with clopidogrel, which is Plavix or any antiplatelet agents, are not recommended to risk reduction of stroke in patients who have atrial fibrillation. It might be great for peripheral vascular disease like carotid artery disease, but it is not recommendation. So the determination is, I like it. If it is less than 1%, I will not give any anticoagulation. 1 to 2%, I'll discuss with the patient, share decision making, and see where the patients are. And if they are not very low or high risk for bleeding, they are amenable, I would prescribe them a DOAC. If the patient is more than 2, I insist they should be on DOAC, or some alternatives we'll talk in a second here. But aspirin or aspirin plus Plavix or any antiplatelet agent is not a first, second, third line of therapy for anybody who has atrial fibrillation. We are treating the stroke risk reduction has to be an anticoagulant, either a DOAC or sometimes using anticoagulations like Coumadin, the old-fashioned warfarin. So recommendations, number 1, again, level 1 recommendation is patients for patients with AF receiving DOACs, optimal management drug interaction. We should always do it. We want to make sure there's no drug-drug interaction, looking at glycoprotein inhibitors and inducers. For patients with AF, we want to target an INR of 2 to 3. And again, making sure the INR monitoring is therapeutic and preventing too high, too low anticoagulation. This is, I think, class 1 recommendation. The class 3 recommendation, which is we are going to do a harm if we are going to go low dose or 1 day using once a day Eliquis or using half a dose of something to avoid bleeding. And if it is not appropriate to dose reduction based on the patient's profile, kidney functions, it does not help, and it also increases the risk of bleeding. So we do use half dose nowadays, and there are a lot of studies in play right now with addition of some other things, which we'll talk in a second, is acceptable. But however, making sure the patient is taking the medication regularly and following all the advice with the DOACs or with anticoagulation with Coumadin is followed. There are bleedings that are sometimes very devastating. Some of them are non-reversible, like GI pathologies that patient has, AVA malformations, pulmonary or genitourinary, spontaneous intracranial or intraspinal, almost life-threatening or life-curtailing or life-changing due to non-reversible cause. Serious bleeding related to recurrent falls is something that we think our long-term anticoagulation should not be used. Long-term can be used, but I think the things are changing rapidly, and I'm going to spend only 2 or 3 minutes on what an electrophysiologist or the advanced healthcare system of US can help today to reduce the risk of bleeding. And for that, closing that appendage we talked about, and I'll show you a couple of pictures very quickly. Percutaneously is an option where percutaneous closure of the lateral appendage stops the risk of or reduces the risk of stroke. and also at the same time allows us to have patients with high risk of anticoagulation to provide adequate protection. So in patients with AF, moderate to high risk for stroke, which means CHA2DS2-VASc, I consider 3, and a contraindication to anticoagulation like bleeding or fall, percutaneous left atrial appendage occlusion is absolutely reasonable. It's doable. And also, it is also, if the patient prefers, careful consideration, extensive discussion can be led to implanting this left atrial appendage occlusion into this appendage, which is again depicted in two different views on a transesophageal echocardiogram. And that's a space that causes most of the clotting, 90% of the strokes. You can put these plugs. Different kinds of devices are available in the market. I'm not going to go into the details, but those are the things that prevents, and they are very easily done. As you see, we put a small catheter into the left atrial appendage, look around the anatomy, decide which is the best device for that. And I'm sure you'll be able to see this is the device is implanted very well on a three-dimensional structure. You can see on the right side of the echocardiogram, fits into the appendage. After 45 days, patients are basically anticoagulation free. So I'm going to stop there for the stroke risk, and then we'll talk about how every physician can help in managing atrial fibrillation. And like a lot of times I have this patient, like I had slight atrial fibrillation and we did not do anything. And so there is a lot of data dated even in 1990s. This study was done in a rat population where they continuously stimulated the heart to create atrial fibrillation. And it's like atrial fibrillation is like Morgan Stanley. You give the money and the money grows. Atrial fibrillation, once you have a little bit of atrial fibrillation, unless you don't do the risk modification we discussed earlier, it's going to get worse and worse. And at some point in time, you end up with from a paroxysmal atrial fibrillation to persistent to the spectrum of permanent atrial fibrillation. And after that, therapies are pretty much futile, at least getting back them to normal rhythm. And so I think it's very important to recognize somebody complains diagnosing this atrial fibrillation with an EKG. Nowadays, I use iWatches and Cardia as well as other extensive monitoring to diagnose atrial fibrillation and then appropriately treat, do the lifestyle modification and then appropriate therapy. But it's very important to recognize that atrial fibrillation, even minimal, can lead to more problems in the future, and treating atrial fibrillation at a paroxysmal stage or even minimal stage is more important than dealing with a patient who is now in atrial fibrillation for the last 4 to 5 years. So I'm going to focus more on this and less on the more ablative therapy, which I'm going to talk about it in a few minutes. But most important things, I think, are lifestyle and risk factor modification and what we should do and what we should be advising our patients who already have a diagnosis of atrial fibrillation lasting for 2 minutes, 2 hours, or 36 hours. That's very important. So one with randomized trials suggest that moderate to vigorous exercising at least for 210 minutes per week is recommended to reduce and maintain sinus rhythm, increase functional capacity, as well as quality of life. This is a strong recommendation. So patients with AF needs to be motivated to do exercise for at least significant amount of time on a daily basis. And how many times I sit down and talk to my patients before I advise them. And I think that is very important to spend time explaining this, which is a randomized trial with a level of evidence up to B level is very important to know. Multiple times questions come with smoking, and I think smoking cessation and helping the patients to smoke cessation as well improves, again, recurrence, decrease in the recurrence as well as remission of atrial fibrillation. Alcohol consumption goes hand in hand with significant data that suggests that decreasing or eliminating alcohol is absolutely important if you have atrial fibrillation for recurrence as well as the atrial fibrillation burden, how much time you spend in atrial fibrillation. Means I have patients who are on monitors and pacemakers, and I can almost call them and say, hey, what were you doing last night? Because you had a bourbon or something, and like, how the hell you know that? And like, yep, I see this atrial fibrillation coming up overnight on my monitors, and I'm watching these monitors, and I can tell that patient lifestyle and the alcohol has got one-to-one direct relation in several patients. Caffeine is actually not recommended. I would not talk about patients, and I say if you drink 6 cups of coffee or 3 Red Bulls, I think it's a bad idea just overall for health. But there's no real benefit or by stopping caffeine consumption or reducing the caffeine consumption. But I think excessive caffeine is not a great thing. But in patients who do report that every time I drink caffeine and I get atrial fibrillation, I'll say, yeah, don't drink that. But I don't recommend that on a regular basis based on the, again, there's no real benefit of stopping. However, weight loss, very important. And I think with the newer weight loss therapy, I'm a big fan of sending these patients to therapy for weight loss, and it could be non-surgical, and at least getting at least 10% of the body weight off would definitely reduce the AF symptoms, burden, regression, as well as progression of to persistent atrial fibrillation. Weight loss is very important. I need to see a patient very motivated to weight loss. Hypertension, I think, also is important, and maintaining a good blood pressure, optimal blood pressure control as gold medicate therapy is significantly important in reducing the atrial fibrillation. Sleep apnea, I know, but if you look at ACC guideline, it's still a recommendation level of 2B. Do I screen everybody for sleep apnea? Absolutely. I think sleep apnea has got definitely role in hypertension, not feeling well, fatigue, and all those things. Does it reduce the atrial fibrillation? Yes, but do I mandate every patient should have a sleep study? Absolutely not. But I like it. I recommend. Hey, you need to look at it. It's reasonable to screen for obstructive sleep apnea in patients with atrial fibrillation. But I think if you exercise, weight loss, some of those things do help also in sleep apnea. So important thing is we have to have a comprehensive program, whether it's in the community, a primary care can provide, a cardiologist can provide, or an electrophysiologist can provide. But it has shown over and over studies that if you have a comprehensive care addressing everything, including lifestyle modification, AF symptoms, risk of stroke, and associated conditions to reduce AF burden progression and consequences are very helpful. Having a nurse or an APP leading those fronts are very important. Am I the best place to get all these things? Probably not. But a primary care or a cardiologist who is dealing with this with preventive care, I think we can do a much better job of reducing AF, reducing the risk of stroke, heart failure, as well as preventing permanent atrial fibrillation. So I personally, I think evidence-based, and we have got a nice AFib clinic that does great job for those patients that does not need everyday electrophysiology care, but definitely getting that continuous hammering on weight loss, alcohol consumption, smoking is very, very, very important care of these patients. There is a lot of data, and I just brought up one study that shows that treating atrial fibrillation early and maintaining sinus rhythm is very important, and it favors early rhythm control will prevent stroke as well as heart failure. And so there's a lot of, and I'm not going to go because this is another topic by itself, but if somebody has atrial fibrillation, there are multiple drugs, flecainide, propofol, sotalol, amiodarone, and all those things can help in maintaining sinus rhythm. And I think in somebody who is symptomatic, somebody who has heart failure, somebody who is younger, I prefer to maintain sinus rhythm rather than leaving them in atrial fibrillation for the rest of their life. And I'll do my best. Obviously, it's always a shared decision based on what the patient feels about his atrial fibrillation, and what the patient is, a 90-year-old or 60-year-old, makes a huge difference in managing atrial fibrillation if they are symptomatic and if they are showing signs of heart failure. I think those are the patients who need to be aggressively treated. We all know medication works, but not to that level. And so one of the ways outside of the drug therapy is focusing the triggers, which are usually residing in the left atrium, which is very close to where we put this Watchman or a device for left atrial appendage occlusion. There are veins behind those structure called the pulmonary veins that brings the blood from the lungs to the heart, and that's where the triggers are. And we have been able to identify 95% of the triggers that causes atrial fibrillation. And in patients who are symptomatic with atrial fibrillation where antiarrhythmic drugs have been tried, either they are ineffective, contraindicated, not tolerated, or patients don't prefer, they can be considered for a therapy where we can destroy the electrical connections between the pulmonary veins and the heart, leading to long-term remissions, or in select few or select more patients, permanent cure for atrial fibrillation. And I think something to keep in mind for referral as well as managing patients' atrial fibrillation, because all this drug therapy that has been recommended, including amiodarone, has significant side effects, and their efficacy at the best in most of the studies are less than 50%. And in the recent past, which is 2 years ago, pulse field ablation came. So there are three ways to destroy these electrical cells, either by freezing, which is called cryo, radio frequency, which is heating the tissue, and then now delivering high voltage electrical currents to the cells and just selectively destroying the electrical cells that are the ectopic foci in the pulmonary veins remain the gold standard. So pulse field ablation is now in play for almost 2 years since the FDA approval, in actually 1.5 years since the FDA approval in US, but been used in Europe for over 5 years. And basically it causes irreversible electroporation, destruction of the triggers without causing any significant damage to other tissues, particularly the nerves that supply the diaphragm called the phrenic nerve, or the esophagus, which causes significant damage or risk of having esophageal perforation while doing the ablation. And multiple catheters, these are the two ones to depict, are catheters that goes into the pulmonary veins, as I mentioned, different size, shapes, and they're all based on the pre-mapping on what we think is the best fit to a patient. But essentially, in contact, it will deliver a very high voltage pulse for 2.5 seconds to cause that permanent destruction of the electrical cells. And that leads to cure or remission of atrial fibrillation for long term. And this is how we do it. We use X-ray as well as the ultrasound, create three-dimensional electroanatomical mapping. And as you see on the left side, this is all focuses as well as foci and fibrosis of electrical instability leading to atrial fibrillation. And after the destruction, electroporation of the electrical cells, we can achieve a homogeneous media that will maintain sinus rhythm in the left atrium, leading to permanent cure or remission in several patients. All right, I think I'm doing good on time. Cancel or proceed with the surgery? And do I start anticoagulation, or should I refer this patient that we talked about, 80-year-old female who is here for a pre-op clearance? And that is determine heart rate, stable, not stable, blood pressure, stable, not stable, any signs and symptoms of heart failure. If stable, proceed with the surgery and then refer it, because it's going to be beneficial to know that she gets this tumor out, gets the therapy done for cancer, which could be life-threatening, lethal. Atrial fibrillation is not going to kill somebody today or tomorrow, but at the same time, risk stratify these patients, get an echocardiogram to look at the heart, and there is no need to cancel this surgery if the patient is stable. Obviously, the patient is not stable. Call a friend, call Dr. Gulati, or if you've got connections, you can get more further with the electrophysiologist, and hopefully they'll take care of this patient before we get to the surgery. But this patient is stable. There's no need to cancel surgery, no need to start a blood thinner. Patient's hemoglobin is 10. She has an ovarian cancer. That's going to bleed. Her risk of stroke is probably, we calculate at 6.8% per year, but it's not tomorrow. It's over the next 1 year. It's 60% in 10 years. Let's worry about the present. Stable, consider this. Let's not cancel the surgery. Then we can get all the workup, EKG and everything else, calculate Chadwick score, start rate control like beta blockers or calcium channel blocker, and then consult the electrophysiologist. No need to change the immediate surgical plan. Again, I think this is something we do all the time, and it could be a cataract surgery or something, and I find it's not that crazy or serious. Yes, it's serious over the period of time, but not on the present day. And if you think the patient is stable, otherwise, there's no reason. But at the same time, evaluate this patient, get all these things done, and then let's start the therapy for this patient. Rate control is the first line. Get the rate control, rhythm control. That's where I think electrophysiological cardiology should be in play. Rhythm control is more important for younger patients, symptomatic congestive heart failure, and I think early rhythm control is very important in overall outcomes with these patients. So role for me in patients with atrial fibrillation is confirm the diagnosis, make sure it is paroxysmal persistent, give advanced therapies to these patients, device-based therapies. We didn't talk about pacemakers, cardioversion, CRT. And again, getting the patient involved, making that shared decision, alcohol consumption, smoking, reduction of weight, treating the obesity, If at all we believe in sleep apnea, then treat the sleep apnea as important. Role of everybody else, particularly the primary care, identification. Use appropriate monitors, iWatch, whatever is available, get the risk assessment done. Management of comorbidity is very important. I don't do a good job that, but my primary care partners and my general cardiologists do a great job of doing all those things, helping me out. And then initiation of anticoagulation and rate control, preventing or reduction of stroke, embolic phenomenon, and reduction by rate controlling tachycardia-induced cardiomyopathy. And then coordination of all this referral, making sure they are followed up. We are doing this on a 6-month basis or a yearly basis is very, very important in managing long-term care for patients. So I think atrial fibrillation is not a problem of cardiologists. It's not a problem that electrophysiologists can fix, but we all can work together to achieve a beautiful light like this in Cincinnati, Ohio. You can see this every night when you come to Cincinnati in July, the Northern Lights in Cincinnati. Now that's a lie, but this is a picture in Cincinnati for Northern Lights. Thank you very much for your time, and I'm open for questions. And exactly at 8:45 as requested by Dr. Govil.
Thank you very much, Dr. Gandhi. This was a great talk, and you've done amazing. You put together excellent slides and presentation, and the fact that you are explaining it specifically not to your electrophysiology fellows, but to non-cardiologists, because as Dr. Gandhi said, that atrial fibrillation, if everybody lived till 200, everybody will get it. And one of my attendings used to say that the person who wrote the textbook of electrocardiogram forgot to write that atrial fibrillation is the normal rhythm in older people. It's so common that it's rampant. So Dr. Gandhi, thank you very much for such an exceptional presentation on this Zoom conference. Your insights and your expertise, and you do this day in and day out, will make a difference, all that you have taught all of us, and we are grateful for your valuable talk and time. We have a few questions. I will take the questions from the chat group and then the ones that people sent to me on my phone. So the first question here is from Dr. Manjari Aravamuthan, Go Apio, Northern California. She's one of our excellent primary care physicians in Northern California. She is asking, is there any increased risk of atrial fibrillation with omega-3 ethyl esters? Is it contraindicated in patients with AFib?
No, there's no any scientific evidence based on that. And again, every medication, if you look at the literature of the medication, will say causes risk of atrial fibrillation. But I don't believe that. But I always discuss with the patient, if you feel anything abnormal, then you can always contact and get an EKG. And I use iWatch and monitors rampantly on patients who are at high risk for atrial fibrillation.
Thank you. I'll put one of the fastest answers in here, quickest questions. Do you check thyroid function on everybody? This is a question.
Absolutely.
Yes.
Absolutely. Thyroid function is a mandatory thing for every patient. The reason are, if the patient has CASWAS score of 0, so if there's a 40-year-old female present, not a female, 40-year-old male presenting in my office with atrial fibrillation and the thyroid levels hyper or hypo, I would start them on anticoagulation. Patients with hyperthyroidism, hypertrophic cardiomyopathy, and some other patients with non-compaction, doesn't matter what their age, CASWAS score, they should be on anticoagulation till the thyroid function. So thyroid function is absolutely mandatory in every patient who has atrial fibrillation. They might look euthyroid, but you never know.
Thank you. Yes, this was a question from Dr. Sharad Goyal, and hypothyroidism, hyperthyroidism, both can contribute to AF. So definitely hyperthyroidism a lot more. Another question is from Dr. Sanyogita Sawant. She wants you to talk about what if this particular patient that you presented at the beginning of the presentation, what if it was totally elective surgery in the same patient and no records were available?
So patient comes to the OR and the patient is already on the surgical table and the patient goes into atrial fibrillation is what I think she's trying to ask. And if that is the case, then in that case, rate control, get the surgery done, make sure the blood pressure is fine, all is well. And then after the surgery, we can have the cardiologist look at it and whatever needs to be done, including anticoagulation with consultation with the surgeon. If the patient was in the pre-op area and getting an elective surgery and has atrial fibrillation with no known history, if the patient says, I have no history, no idea of any atrial fibrillation, this is the first time I'm diagnosing atrial fibrillation as an anesthesiologist or a surgeon, totally elective surgery that is not going to impact the patient, I would postpone the surgery and get the evaluation done because atrial fibrillation could be a marker of low ejection fraction. You don't go into in a surgery that is totally elective without any baseline data available at the fly of the moment.
That's very helpful. And then there is a question from Dr. Nihal Shah. And by the way, there are tons of compliments in the group chat, and everybody is saying excellent presentation, which it is. So the question from Dr. Nihal Shah is, being a psychiatrist, we do treat adults with stimulants, and many of them take it for years. Are they at an increased risk of atrial fibrillation or any other arrhythmia besides SVT? Do you suggest any other routine other than follow-ups yearly on for an EKG, annual ECGs? And also, is there a dose or duration effect? Especially many of our patients are smokers and use caffeine too.
Yeah, great question. So with ADD diagnosis or using Adderall or stimulants, there is definitely an increased incidence of sinus tachycardia and supraventricular tachycardia. No real randomized trial, obviously not done because it's not possible to do it, but there is an evidence of increased atrial fibrillation. Personally, I believe if you stimulate the heart too much, everybody can develop atrial fibrillation. So moderate, judicious use and not using it rampantly on everybody would be my recommendation. Also, risk modification. So if the patient is obese, hypertensive, diabetic, and you're going to give them medication like that, I would be very careful in monitoring and advising the patient. If your heart races, get an EKG, get an Holter monitor, get iWatch. On the other hand, I think psychiatrists are very important in this because there are drugs that we use that causes the prolongation of one of the intervals of the heart called QT. And so if your patient is on sotalol, one of the example of QT prolonging drug, and you give a drug which is for depression and that can cause more QT prolongation that can lead to lethal arrhythmias like ventricular fibrillation and monitoring those things. So if you're giving somebody long term, you have to make sure that the patient's cardiologist or primary care is monitoring with an EKG, and anytime there's an evidence of QT prolongation, if you change the dose, if you change the drug, having another EKG to make sure that they are not prolonging their QT that can lead to catastrophic events like ventricular fibrillation. So I think as a psychiatrist, if I was prescribing a medication, if somebody was on antiarrhythmic therapy, I would say I will contact the primary care or cardiologist. Hey guys, I'm starting this. This is important for the patient, but I want you guys to monitor those things. So it's very important to have that comprehensive care. Again, that's why I said comprehensive care, where things change on patient's life. Having a nurse or APP directed clinics that are monitoring those things on a regular basis are very important.
Thank you. That's a very good answer. There were 3-4 questions in that one chat box, and I think you touched on everything. Since the definition of atrial fibrillation has changed from the past and now we have the new definition, one of the questions that is asked over here by Dr. Balakrishnan Arivalagan is, in case it's paroxysmal atrial fibrillation, if we come across AF case in clinical situation, should we wait for 7 days to let it settle on its own and see if it goes away?
Yeah, it's tough. Yeah, it's a great question. And we deal with this all the time, right? So how many times patient ends up in the emergency room because patient is in atrial fibrillation? They call my office, I go to the ER, and the next day they're back to normal rhythm. And the answer always, oh yeah, they gave me some medication through my IV and I get to normal rhythm. And that usually is metoprolol or IV cardizem, and that has got nothing to do with the conversion. So majority of the patients, but it's so difficult to predict. So what I do, and this is what day-to-day life, right? So if somebody has paroxysmal atrial fibrillation and the CHAS score, say, for example, 4, so I'm putting a very high-risk patient with paroxysmal atrial fibrillation, I give them pill out of the pocket, which is 3 pills of flecainide, and say, pop this flecainide and take a blood thinner. I'm not going to do the blood thinner just for 12 or 6 hours of atrial fibrillation, but I think if somebody stays for more than 24 hours, I want them to be on anticoagulation so that they are protected from stroke. So pill out of the pocket is a great approach in some patients, select few. And again, I would not do it as a primary care. I would not probably do as a cardiologist. I would do it probably as an electrophysiologist. But that's one of the ways to treat. But anytime somebody has paroxysmal, it is time to call the specialist. And I think waiting for 24, 48 hours is reasonable if we are taking care of the rate, heart rate. If we are taking care of that anticoagulation factor in the CHAS score, I think it will be very important to assess that and then treat the patients. And majority of the time, the patient will get back to normal rhythm without doing anything, but it's a flip of a coin and you never know what's going to happen. So I deal this on a daily basis. Particularly, it's a medical doctor, and like, I got an AFib today, and like, what should I do? And like, okay, pop in some pills, and we'll see what happens tomorrow, or get ready for a cardioversion. And cardioversion, I like patients to be in less and less AFib as possible because it's like money. If you have some money, you're going to get more money, and if you go to a date, you're going to have a girlfriend, ultimately a wife. So I would be very careful.
Yeah, if atrial fibrillation begets atrial fibrillation used to be the old adage in the textbooks.
It
The
is
more
still there.
you have, yeah, it's still there. Okay, so just 2, 3 more questions. One of them is from Dr. Narendpal Singh. AF occurs in the elderly. All these scores on either side will be more in the elderly. So what path to take? So I think he already answered this based on the CHADS-VASc score and the Hasbled score. Would you want to touch on that subject again, Dr. Gandhi?
Yeah, I mean, being an invasive electrophysiologist and having all this, and I feel, means again, we have to go through the guidelines and obviously Medicare rules and regs for payments and everything. But I think it is absolutely important to treat anybody who is 80-year-old with hypertension with anticoagulation. And these are the highest risk patients for bleeding. And for them, early intervention like left atrial appendage occlusion is something that I consider as my first line of therapy. Obviously, there is a fall risk. How many times you have to fall? And there's some data. They said if you fall 9 times, it's very bad versus 2 times. But one fall is one fall, and you can hit the head and you can have bleed. So I'm very aggressive, and I think I would say, looking at it again, it's a shared decision. This is a patient's world. We are providers. We are not the final decision maker. Patient makes the decision, and shared decision is so important in every aspect. And I think atrial fibrillation is a chronic condition. Shared decision, what does the patient want? And obviously, ultimately, what does the insurance want to pay is important. But still, I think our recommendation should be based on what we feel is the right thing for the patient.
Thank you. This is very important because there are some patients who will not take anticoagulation no matter what you tell them. And one of the questions I remember early on in fellowship, I had asked, what do you do? And my attending said, okay, you decide. Do you want to be called with a stroke that's secondary to a bleed? Or do you want to be called by a stroke that's secondary to an embolic event? So it's a difficult decision, and shared decision, I think, is very, very important, as you have touched on it. So another question from Dr. Jaswant Jain. Can you please tell how you treat young AF in young patients? So I suppose he means new onset AFib.
Absolutely. So I'll give a very quickly example. 54-year-old gentleman who happens to be a physician and happens to have hip surgery because of bad hip because he was standing and doing fluoro for the last 20 years of his life and has atrial fibrillation. And we treat him, a couple of cardioversions, get him back to normal rhythm in less than 24 hours, anticoagulation. The guy is miserable. Talk to him, say, okay, I'm going to go early on. I'm going to give you any medications other than what I've given and going to do an ablation. And today, 2 years later, he's happy, no atrial fibrillation. 60-year-old gentleman with pneumothorax in the past has atrial fibrillation multiple times, hospitalizations. and doesn't want to take any therapy, doesn't want any blood thinners. I ablated the patient. So I think younger patients, I'm pretty aggressive. Guideline says failed or preferred not to use antiarrhythmic therapy by the patient. And if those are the case, early ablation in patients with atrial fibrillation dependently decreases or probably eliminates atrial fibrillation. I'm so scared of saying atrial fibrillation cure, even in a
Ramesh.
50-year-old patient, because that's never true, or it might be true. But I see long-term remission with patients on ablation, and ablative therapy has become faster. With PFA, risk is very low, and the success rate is close to 90%. Most of the data is suggestive of paroxysmal atrial fibrillation in young patient with no other risk is around 90%. So I think ablative therapy is great. Antiarrhythmic therapy and any medications like rate control medications like beta blockers in a 30-year-old guy is just not going to work on the long term. And I think we have therapies that we need to expose these patients very early on rather than being shy. And the guidelines are changing. Guidelines will change in the next 5 years, that it will become a class 1 indication in patients as a primary therapy for atrial fibrillation would be an ablative therapy.
Okay, so most of these questions came from different specialties, and now we have the cardiologist's questions coming in. Dr. Parekh has asked, and I'm going to throw 2-3 questions together at you. One is from Dr. Pankaj Parekh. He wants to know any options to stop the DOACs after ablation.
Okay, so DOAC ablation. Right now, data is if the chest VAS was 0, I would use just peri-ablative anticoagulation, meaning I start before a week and end up in 3 weeks. If somebody is a chest VAS 1, I'm very comfortable. Chest VAS 2, I'm very comfortable. Chest VAS 3 is shared decision. Chest VAS 4, they need to continue anticoagulation. There is no guidelines on that. There is some data that is going to come out very soon for some trials that will suggest that if we are very sure that atrial fibrillation has been taken care of with regular monitoring and chest VAS 3, we can easily stop anticoagulation. But right now, I think treating patients for atrial fibrillation to stop anticoagulation is not my recommendation. I'll always tell patients my anticoagulation regime will depend on success, but already I know if your chest VAS is 4, I'm never going to tell you to stop anticoagulation. Now, what I offer now is combined procedures for patients who have those two things need is do the ablation and put a left atrial appendage occlusion device at the same time, which is a concomitant procedure. It takes me 20 extra minutes to occlude the left atrial appendage. And these patients, even if they have recurrence of atrial fibrillation, they can be off anticoagulation for the rest of the life. So there are two different distinct pathways. And I really believe telling patients to say, I'm doing an ablation to stop your anticoagulation, we have no data to stand on that right now.
Thank you. And then in your CHA2DS2-VASc score of 2, after ablation, do you at least do 3 or 4 weeks of anticoagulation, or you just hold?
Absolutely. 3 weeks to 4 weeks minimum. I need to know how the success is. I like to have a loop recorder or some kind of monitoring. And
Yes.
again, it's a shared decision. I'm going to go for shared decision over and over again here.
Okay.
Unless I put the devices like Watchman. I will never put a device like that in a chest VAS 2. So chest VAS 2 real brain's really controversial what to do. A lot of people will believe that if we have got a good idea, patient is compliant, I've got a good monitoring system that will tell me they're going to have a recurrence of atrial fibrillation, it is safe to stop anticoagulation. But again, I would say that recommendation would be not randomized. Recommendation would be there is no data for that.
Okay. All right. So one question from Dr. Ravindranath Bhatina. Any risk of pulmonary embolization from right atrial origin?
Well, a great question. So no data, no suggestions, nothing that we know of. And I always have wondered what does the right atrial appendage does in this thing. And I think lung is a great filter. And I'm sure most of the embolies that happen, if at all they happen in patients, probably are very small that has minimal consequences. But I have not seen any evidence of that or in the literature suggestive of looking at the right atrial appendage and anticoagulation after device therapies or ablation.
Okay. And how many times would you ablate a person? The recurrence rate of atrial fibrillation after ablation in a patient with paroxysmal AFib versus recurrence rate in somebody who has persistent AFib?
Absolutely wonderful. Greatest question of the world, I think. Paroxysmal atrial fibrillation, I think if the patient has atrial fibrillation, if I do an ablation, has a recurrence, There's no guidelines when to do the next ablation, but I would offer a next ablation if the patient has 2 to 3 recurrence in 6 months after the first 3 months of blind out or washout period, and I'll opt for them. If they have another recurrence after that, I need to start looking for what are the other triggers and what else can I do. And there are a lot of other triggers that doesn't reside in the pulmonary veins, and taking the posterior wall out or taking the superior vena cava out, and all those things are ablative procedures that has got minimal yield. And after 3 hours, use the statement, doing the same thing over and over again, expecting a different result is nothing but insanity, and not recommend the same ablative therapy for the fourth time. There are surgical options where patients can go and have an epicardial ablations and all those things. It's again depends on what the patient wants to achieve, what's the patient's age. Recurrence after paroxysmal atrial fibrillation is much lower than recurrence after a persistent atrial fibrillation, so early intervention and doing early ablation is definitely recommended. If somebody has long-standing persistent atrial fibrillation as defined by more than 2 years, the success rate at the best of the best centers and with the best of the best technologies, including PFA, is less than 50%, meaning of flipping a coin, versus there are other options like conversion procedures using a surgical partners, and surgical ablation might have a slightly higher yield. But I personally believe once patient has an atrial fibrillation continuously for 2 years, to achieve long-term durable success, meaning defining more than 1 year with no atrial fibrillation, is probably an oversell of the procedure like an ablation.
Thank you. Okay, two more questions here, and then I think we should be done here unless another question comes. There's a comment from Dr. Yashwant Chaudhary. It's a comment. Post-ablation, you get sinus rhythm, occasional AFib. Aspirin is no longer recommended. Thank you for that. And the question here is, how long, it's great to keep everybody in sinus rhythm. How long do you use? What's the longest period you have used an antiarrhythmic?
Well, long-term antiarrhythmics, starting from class 1C, which does not have any long-term side effects, and if somebody is tolerating medications like propafenone or those type of medication, I will use them forever. I have no problems, and unless they develop coronary artery disease or left ventricular hypertrophy, so monitoring them with stress test and echo is very important. Patients with sotalol, if they don't have any issues with renal function and if they're tolerating sotalol or ticosin, I'll continue them for till they have recurrence or they don't have any side effects, I'll continue. Amiodarone is one I really worry, and if particularly younger patients, I think
That's
I
the
want to
question.
have a vigorous monitoring, which is four things: eye examination by an ophthalmologist, or making sure the optometrist is looking at the cornea and not the other areas, because the deposit happens in the cornea that can ultimately decrease the vision. Number two, checking their thyroid function every 6 months, making sure pulmonary function test, which includes DLC or diffusion lung capacity, is very important to be monitored once a year. And last but not the least, liver function test. And any abnormality should be addressed immediately. And X-ray chest to make sure pulmonary fibrosis and a CAT scan also sometimes might be important. If you are doing all those things and the patient is in their 80s, I'm very comfortable leaving them on amiodarone with that monitoring, that rigorous monitoring, and stopping things as soon as needed. In somebody who is 50, 60 years old, I get very nervous. My drug of choice is ablation and not using a medication.
Okay. So two last questions. The first one is, I guess if you don't have to necessarily answer it here because it's a question on, well, how about the diastolic dysfunction in the atria after multiple ablations?
Absolutely. No, great question. It's a big quagmire as well as an enigma that patients do come. We have seen this multiple times, and not even just doing an ablation, even a cardioversion. And patients sometimes, and I've got this patient who I remember very distinctly, first time I cardioverted went into pulmonary edema to the extent got intubated after the cardioversion, and no other reason, normal EF and everything else. And we'll see this anecdotal incidents, but absolutely. And we have seen with ablation decreasing the left atrial function by almost 30-40%, and taking out that left atrial appendage also has some implications. So yes, these are very important. Multiple ablation can cause atrial stiffness, that can lead to more diastolic dysfunction. And those are important things to keep in mind, particularly when you're doing these procedures in younger patients. And my philosophy has been the less is more. And so if I'm just doing a pulmonary vein isolation, which is just going in the veins, I think it causes less of that scarring and the left atrial diastolic dysfunction. But if I do an extensive ablation, knocking out the posterior wall, the roof, and the floor line, I'm very, very careful in those things. And I think they are very important areas that maintaining sinus rhythm. I'm not a plastic surgeon. I'm not here to make patients' EKG look better. I want the patient to be better. So I'm not doing plastic surgery on a patient with atrial fibrillation.
Well, that's a very good analogy. I'm going to use it on my patients when they ask me that they want to go back for a procedure, should they or should they not? Because on the radio and television, it is so publicized that patients come asking for the procedure. So last question, because I see our Dr. Hetal Gaur, she's an OBGYN. So I'm going to throw this question in for all the OBGYNs out there. Can you please touch upon anticoagulation in a pregnant lady who's diagnosed with atrial fibrillation?
Absolutely. That is one of the nightmare scenario.
That's why.
And
That's why I'm tossing it to you in the end.
obviously, you want to make sure there's no factor V Leiden and all those things. Obviously, as
Yes.
everybody knows, warfarin and anticoagulation with Coumadin is definitely a big no-no. Eliquis, Xarelto has been looked at a little bit. Lovinox is your best answer. And people can be on long-term Lovinox, and I think that is the best answer at this point in time, and try to minimize anticoagulation as much as possible, but that's what I would use.
Do
And
you
it's
ever
very,
do?
thank
Do you
God it's very rare. Means it's a nightmare situation.
We see it a lot with the mechanical mitral valves, in which we have to deal with anticoagulants, not necessarily with mechanical valves and AFib. But if you do get a patient like that, would you, because nowadays women are getting pregnant later and later in life, and AFib risk increases. So the question here is, do you ever do a bridging? So, change from Lovenox in the beginning, then Coumadin for the second trimester, and then 4 weeks before do you ever do those things anymore?
To full disclosure, I'm not an expert at either of those things. So I would say I have no idea if anybody else in the audience knows what to do. For me, it is like call the other guy because he knows much better with the structural guys or general cardiologists and they deal with it. But for me, I have never used anticoagulation with Coumadin in a pregnant patient. I would not prescribe that.
So I have actually, with the valve case, this was a while ago, but I dealt with a lot of those patients. So we gave them low molecular weight heparin initially, and then in the second trimester changed them, and also up till the third trimester, and then 4 weeks before their due date, we would take out because they can deliver any time, and you can have a high risk of hemorrhaging if they're on Coumadin. So actually change them back. And it's a problem because Coumadin crosses the placenta and there's, consideration for birth defects and then the fetal warfarin syndrome. So it's very hard and you have to work very closely. And it's better to give them the heparin or low molecular weight heparin rather than to give Coumadin. Yeah, it's a difficult one. And that's why I saved it for the end. So unless there is another question, I hope I didn't miss anybody's questions. If I did, forgive me because I am squinting at all of them and making sure that I didn't inadvertently miss anybody. One last question,
There's
Dr.
one question. Yeah, Anjali. Yeah.
I missed something. So the one
In
question,
is ESRD. Yeah, yeah.
where is that one?
That
There
is,
is-
yeah, by I think Sarika Deshmukh.
Let me
Question.
see. Let me see. I'm looking at all the things. Is it towards the end or the beginning?
It's
Oh,
towards
yeah,
the
she just
end.
asked about, yeah.
ESRD patients, do they have any
ESRD
different outcome?
patients.
Yep,
Yes,
without ablation.
yes. Okay, and then I think we are all good. I would say, Dr. Gandhi, this is an excellent overview of atrial fibrillation, not just for the non-cardiologists, but also for us. It's always good. The one other question I wanted to talk about, but I guess this is not the right place, would be the channels, the channel changes in chronic AFib versus new onset AFib, and if your drug preference changes depending on how long they have been in atrial fibrillation.
Say that question again so I can answer it.
Well, if the person has, you want to maintain sinus rhythm and the patient has just been in AFib for a few days versus somebody who's been in it for years, do you have a specific drug you would use in one patient versus the other?
Oh,
to
absolutely. So paroxysmal, or it's somebody who has new onset AFib, I'll do my best to keep that patient in normal rhythm, and I will use antiarrhythmic therapy. If somebody's in AFib for 5 years, rate control, rate control, rate control, and I will do everything to control the rate and stroke prevention, which would, and there is some data that permanent or long-term atrial fibrillation is a slightly higher risk of stroke. Actually, I'm participating in a trial where they are comparing, can you put a occluder device and continue anticoagulation, and can that prevent stroke related to chronic atrial fibrillation? Because pulmonary atrial fibrillation is definitely a higher risk compared to paroxysmal atrial fibrillation, though it is very slight difference in a couple of randomized trials.
So then you are treating these patients with occluder devices and antiarrhythmics.
Anticoagulation, so it's double dose.
Anticoagulation. Okay,
Yeah, but again, it's at a research level right now. I don't think that's the standard of care, but this is a research level that people do believe that patients who have permanent atrial fibrillation are at a higher risk of stroke. And I'm sure you have seen, and I'm sure everybody else has seen, patients who are taking anticoagulation still end up with a stroke. And patients with left atrial appendage occluder device end up with a stroke too. And those are the enigmas. Like, what did we do wrong? There's no DR, devious thrombus, or there's no leak. Patient was taking blood thinners twice a day, apixaban 5 milligrams twice a day, and why did the patient have a stroke? And we have no good answer. And I believe that patients who have long-term atrial fibrillation have remodulation of their appendage, and they are more thrombotic than patients who go in and out of atrial fibrillation. Again, not too much data to support that, but there is significant shift in thinking about permanent atrial fibrillation and stroke risk compared to somebody who's paroxysmal.
So if they have failed a DOAC, do you then consider either changing the DOAC or measuring the 10A levels, or do you put them on Coumadin?
All of the above. And then I'm very sure that I want to look at the left atrial appendage very closely with multiple views on the transesophageal echocardiogram as well as a CAT scan. See if there's any evidence of anything that is causing thrombus that is formation. And if patient was taking Eliquis, making sure they are taking it and change it probably to Coumadin so that I know that they are taking. I've got an INR of 2.5, but it's sometimes intuitive to my brain because we already have proven that Eliquis or anticoagulation with DOAC is better than warfarin. Multiple studies, and why I'm going to an inferior study. And so I try to get those guys convinced if there is no clot, there's no evidence of any other reasons to have a stroke, and they're still having stroke, to consider left atrial appendage occlusion or left atrial appendage elimination by surgical methods too. So I think getting rid of the left atrial appendage out of the picture is very important than putting a band-aid like an anticoagulation in patients who are having multiple recurrent embolic events in spite of being on adequate therapy with DOAC or with anticoagulation. And I have a patient very quickly had initial stroke to on Eliquis, so I changed her to warfarin, got a therapeutic warfarin, didn't do any difference. And I was very aggressive and put a device. And for the last 12 months now, patient has not a single event of TIA. And I left her on low dose Eliquis plus plus the occluded device. Again, this is experimental. This is not what I recommend.
Okay, thank you very much. So the last question, this is literally the last question, and the two people have commented on it. One was asking the side effects of amiodarone, which you already touched. That was from Dr. Vinod B. And then there's another thing which he's asking, what would be your preferred antiarrhythmic in an 80-year-old with low EF and paroxysmal AF? Are side effects of amiodarone dose dependent? Is there a safe dose of amiodarone?
Yep. So they are dose dependent, but there's no safe dose of amiodarone. So 80-year-old gentleman, otherwise very functional, no other side effects, I still think I would definitely offer a therapy that is medication, which means ablation, as one of the choices. Low EF is one more reason to treat atrial fibrillation more aggressive. If you look at any data that came out in the last 5-6 trials with atrial fibrillation comparing antiarrhythmic therapy compared to ablation, and these are sub-studies, so I don't like to make generalized statement, but Cabana was the biggest study that was done, NIH funded, totally neutral study. And if you look at the subset of Cabana trial, if patients have low EF, maintaining sinus rhythm using non-pharmacological therapy, which means ablation, has proven without doubt is superior compared to rate control or using antiarrhythmic therapy. So I think if you look at that, if somebody's heart failure, patient has to be appropriate. I don't want an 80-year-old patient in a nursing home getting on my table for an ablation, but if it's an 80-year-old very agile guy and EF is 30%, and I would offer them an ablative therapy.
Okay, thank you very much. So I guess all of us have learned a lot. Thank you so much for taking your time and giving us your insight. So on behalf of AAPI, Dr. Kathula, Dr. Govil, I will say thank you, and I'm going to hand it over to Dr. Govil. Thank you very much, Dr. Gandhi. Really a pleasure to hear you.
Thank you very much. Thank you, everybody.
Thank you. Thank you. This was a great presentation, Dr. Gandhi and Dr. Gulati for moderating. This was a wonderful evening, and I'll hand it over to Dr. Kathula for presenting. And before I sign off, I know it's almost the end of the year for AAPI, an exciting year for me, and I'm looking forward to the last webinar, which would be next Wednesday, and we'll share that information soon with you. So stay tuned, and I'll hand it over to Dr. Kathula.
Thank you, Dr. Govil. Thank you, Dr. Gandhi, for excellent presentation. Dr. Gulati for amazing moderation. And we do have a small token of appreciation for Dr. Gaurang Gandhi. Ms. Vijay, can you please put that on the screen, please? Yeah, American Association of Physicians of Indian Origin recognizes Dr. Gaurang Gandhi, MD, FACC, FHRS, for his outstanding contributions in the field of electrophysiology and cardiology, and welcomes him as a member of AAPI Distinguished Speakers Club. Satish Kathula and Amit Govil, June 11, 2025. Thank you, Dr. Gandhi, for excellent presentation again. And thanks, everybody, for joining. Again, please register for the National AAPI Convention, Annual Convention in Cincinnati, July 24th to 27th. So please do not forget. Thank you so much. Have a good night.
Thank you. Thank you, guys.
Good night.
Good night. Good night.
Good night.